At The Nocturnist, we are careful to ensure that all stories comply with healthcare privacy laws. Details may have been changed to ensure patient confidentiality. All views expressed are those of the person speaking and not their employer.
When a person is hospitalized, not only do they lose their health, but also their agency, since the hospital takes over their entire daily routine. What's it like for the doctor when patients attempt to reclaim their autonomy in ways that are frustrating or even dangerous? I'm Emily Silverman, and this is The Nocturnists, stories about what it's like to work in medicine. In this episode, pediatrics resident Dana Gall tells a story about a young woman who railed against the hospital environment and the challenges that came out of it. Afterward, we talk about the complexities that arise when caring for children in the hospital and how we might try to give back a sense of control to our patients, even with actions that may seem small. Without further ado, here is Dana Gall.
Hi, everyone. I don't have any family members who are in medicine, and since starting being a doctor, I've noticed that a lot of people I meet ask me what it's like to be a doctor. And a lot of the times that question goes like, what's it like to be a doctor? And before I can even answer, they say, is it just like House? And I have to say, oh, there's not quite as much excitement in our diagnoses. There's a lot more common things being common. And then they say, okay, then is it like Grey's Anatomy? And I say, well, I think there's a lot less sex happening in supply closets, but that's only as far as I know. So then they, of course, assume, well, maybe it's like Scrubs, and I have to say, fewer of us are well-rested, eating all together in the cafeteria, pulling pranks, and when I'm running down the hallway, it's usually to catch the shuttle, not to a code, and my hair doesn't splay out nicely from my face. It's like this in the wind. So no, it's not like any of those things. And what I really think about is that I spend most of my days as a doctor wondering things. And a lot of it is really benign stuff. I'm wondering what the cafeteria serves and crossing my fingers that it's Ethiopian Day. That's my favorite. Or I'm wondering if the night intern is going to get in on time so I can make it to dinner with a friend or with family. I'm wondering how I can help my co-interns or now my co-residents, how I can teach med students better. But most of the time I'm wondering what my patients are thinking, what their parents are thinking. It's something that I can't stop wondering about. And because of the power dynamics in medicine, they often don't necessarily share that with you. But it is something that I spend a lot of my time wondering about. I'm wondering, if they're satisfied with their care, if they're afraid, if they even understand what's going on, if they know what's going on at all. And I found that while my career has not been that long, in this time there is one patient in particular who I have not really been able to stop wondering about. She had type 1 diabetes, as well as an eating disorder that she was struggling with, and multiple infections that were causing her a lot of pain. And she's over 18. She's over that magical, arbitrary age in our country where people are adults and are able to give consent. Usually in pediatrics, we deal with patients who are giving what we call assent or assent. They're not legally capable of agreeing to treatments or procedures, but in this case she was. Or more importantly, she was able to refuse treatments and procedures, which was very challenging. And in the hospital, something to remember is that people lose all their control. They come in and they're these autonomous individuals, and we take away their clothes and we give them a nondescript gown. And we take away their schedules and we wake them up every 4 hours or sometimes even more often to check their vital signs. And we take their blood and their sweat and their urine and sometimes even their tears to test things. And I think that in her case, a lot of what was challenging for us was this struggle between who had control in the different situations. There was one day that I remember coming in on the weekend. I was there on a Sunday, and my attending and I walked into the room to check how she was doing. And she pointed to a row of perfectly stacked Sierra Mist soda cans. And she has diabetes, so she's not allowed to have soda. And she just pointed to them. She didn't say anything. And we asked her, what are those doing there? And all she said was, I can have them if I want. And And I remember in that moment feeling really frustrated because here we were having really challenging times controlling her blood sugar, trying all different medication regimens, changing things up all the time, and having really little success. And there's a whole row of sodas that potentially could be the whole cause that her blood sugar was completely out of whack. But she never drank one of those sodas. She knew that it wasn't good for her. She just wanted that control, I think. She was struggling with showing us that she could have them if she wanted, but she didn't. Another time, we came into her room, and she pulled back her bed sheet and had salt packets hoarded under the bed sheets. And salt was another thing that she wasn't supposed to be having because of her medical illnesses. And it was the same tension where she knew she shouldn't be having it, and she didn't actually have the salt. She just was proving to us that she could have it if she wanted. The most frustrating one of these experiences for me was when I was on nights. And I got called to the bedside by her nurse because in looking over her chart, it turned out that she hadn't urinated that whole day. And for those of you who are doctors, you probably realize that that's kind of a scary thing to see in your patient. For those of you who aren't doctors, you now have the pleasure of knowing that we spend our time worrying about how much people are peeing all day. And so I went to the bedside to find out what was going on. Was she not drinking water? Were her kidneys having some sort of damage? What was going on? And when I came to her bedside, she said that she was in too much pain to get out of bed to use the toilet. Okay, so we discussed options that could make it so that she could pee without getting out of bed. And we went back and forth on this for a while, and she definitively was refusing any of those options. And what she wanted was an opiate pain medication, and she wanted it to be IV. And this was something that we had been struggling with through the whole time she was in the hospital. And to the point where our team had actually created a whole pain contract in which it was dictated how much of which kind of pain medication she was allowed to have, when she was allowed to have it, what we would do in the event that that wasn't good enough. I remember going back to the workroom and complaining to my senior resident and being fatigued and tired and not able to understand even what the source of her pain was and if we should violate the pain contract that our team had so carefully and methodically planned out, and what would that mean for the next night? Would she just again demand it? And almost feeling held hostage by this situation and not knowing how to proceed. And finally I went back to her room and we talked about it longer, to the point where eventually we actually hit the hour where she was allowed to get more pain medication, at which point she got it, she got out of bed, and she urinated. And this was so frustrating for me. I remember the team coming in the morning and trying to explain to them how challenging it had been to feel like I had no tools, like I couldn't actually do what I felt was medically right. I couldn't not treat her pain, because ethically we've been taught that we need to treat pain. But I was so worried about how we were feeding into what I considered to be an addiction to this medication and what that addiction would mean for her future. So eventually she got to the point where she was able to be discharged from the hospital, and she went home. But I still found myself wondering a lot about her and wondering what we could have done differently in a lot of these scenarios. That being said, we're very busy and I moved on in my mind. And then a few months later, one of my colleagues called her primary care physician to check up and see how she was doing. And we learned that she had actually died. And at autopsy, they had found toxic levels of that opiate medication in her system. And since learning that, I really haven't been able to stop wondering about this whole experience and what it means for us as pediatricians, what it means for our society, and how we can prevent these things. What I can do for myself is say that I will change my practice. I can't necessarily change these larger systemic issues. But I do find myself wondering frequently, maybe if more people had been at her bedside more of the day, something could have been different in the scenario. Maybe if we had been able to give her some more control in one of these decisions, she would have felt differently about her relationship with her physicians and sought out help when she needed it. To be honest, I wonder if she even knew that when she was taking that medication, it was a lethal dose. I really don't know if this was an accident or not. And I wonder about what she was thinking about in the moment that she did decide to take those medications. So now, when I meet people and they ask me, what's it like to be a doctor? I can definitively say it is not like any of those TV shows. What I can say is that every day I practice medicine is full of wonder, but it is not always wonderful. Thank you.
I am sitting here with Dana Gall. Thank you for coming over to our makeshift podcast studio, Dana.
My pleasure.
Well, I'm glad you're here. We really loved the story that you told at our event several months ago now. Yeah. And I'm really honored that you came over to chat about it with me because I think there's some interesting stuff to unpack here. So Dana is a resident physician in pediatrics. She told a story at our event on the theme of wonder. So in the beginning of your story, you talk about how you work in pediatrics. And I think you're actually the first pediatrician to speak at the Nocturnus. And so far, we haven't had any others. So you really bring a unique perspective to this community. And I'd love to hear a little bit from you about unique challenges in pediatrics when you're dealing with a patient population who is less than 18 years old, although it sounds like the patient in this story, in fact, was older than that. But that aside, what is it like working with that population, and how do you imagine that it might differ from the work I do every day where I'm working with people who are 94 years old or 54 years old?
Honestly, I don't think I could count the number of ways in which I imagine it's probably different, though it's been a while since I saw only adult patients. It really impacts every single part of the interaction, whether it's on the inpatient side or the outpatient side. I sometimes joke that the things it might be closer to are like veterinary medicine or geriatrics. You have diapers in both of those settings.
It's a spectrum.
Yeah. But the reality is that there are special considerations for every single age group. So going from, your infant patients who can't actually tell you anything and you're solely having to interpret what their parents are telling you and what they reveal to you in their physical exam or their vital signs or their lab results, all the way up to, a 17-year-old who is probably starting to explore their own autonomy, for better or for worse, and may not want to hear, the authority that their parents actually still do have. And then I think the more complex cases are where you and a parent may not see eye to eye in terms of what's best for a patient's care. And you have to actually really advocate for your patient. And that can be very challenging when the family or the caregivers don't see the same interventions as beneficial to their patient or to their child, excuse me. In this story in particular, obviously the issues of consent and assent are things that I address, but those are really real problems that we deal with day to day. If a child wants to have a vaccine and their parents are anti-vaxxers, you're really kind of up against a wall. In California, we're really fortunate that we have a lot of laws that protect pediatricians for giving certain types of healthcare, particularly surrounding sexual health for teens. But in a lot of parts of this country, if a teenager wants testing for an STI or birth control, that cannot be provided without parental consent. So the differences, I think, are vast and often result in a lot of fun for us, but also can be really challenging.
Wow, it seems like there is such a spectrum within human life expectancy, but even just within the bucket of pediatrics, an infant is a completely different animal, so to speak,
Yes.
than a 2-year-old or even a 4-year-old or a 10-year-old and a 17-year-old. It's just there's such dramatic change.
You know, you're going to diagnose differently in each age group. You're going to consider different pathogens in each age group, use different antibiotics, and have different parameters for when somebody would be considered critically ill versus safe enough to go home.
It's definitely a different beast. Well, next, kind of bridging off of that discussion about control in the hospital. And in your story, you talk about how when patients come into the hospital, to an extent, they lose freedom, they lose control. And you point out that sometimes this can be really upsetting, disturbing for patients, and they react to it in different ways. What have you seen in your patients reacting to this lack of control in the hospital?
People, I think, shuttle that energy into different outlets. I've seen a lot of responses to illness and to hospitalization that I would argue are actually quite positive. As doctors, we often don't want our patients to go straight to Google, but sometimes that can be helpful. That's a place where people can find information that helps them advocate for themselves and ask the questions that they really want answered when they have those opportunities. And so I think, thankfully, that's one of the more common responses I see, actually, that people try to kind of take ownership of whatever is going on. Of course, that's not universal. And so a lot of parents and children will often kind of go the opposite direction. When it comes to kids, I've seen a lot of, reverting to more infantile stages is the nice way of putting it. Temper tantrums and lots of demands and people kind of bending over backwards to make it as tolerable for a kid as it can be. For example, I've seen kids who are, 7 years old, that kind of thing, who have already left for school. And when they become ill, they need their mom like right there in the bed with them, or else they, become really upset and agitated. They go back to sucking their thumb or needing a pacifier, that kind of thing that they've already grown out of. But once they're hospitalized, it kind of comes back to them.
I'm actually remembering back to my pediatrics rotation in medical school and this whole branch of pediatrics that is child life specialists.
Our gods.
And so maybe can you tell our audience what is a child life specialist?
Essentially, their role in the hospital is to make the process of hospitalization more understandable and tolerable for a child. So they are experts in explaining medical procedures to children. They'll do things like if we have a kid who's going to get a G-tube or a feeding tube surgically placed in their stomach, where they'll bring a teddy bear and they'll actually let the kid essentially put a G-tube into the teddy bear so they can see what it's like. If you have a critically ill child or a terminally ill child, they'll even work with their sibling to understand concepts of death and dying, which are, luckily for most kids, things that they don't necessarily have to understand. And they create really strong bonds with patients. They're very, very close with them and follow them through their entire hospitalization and often readmissions.
I can't help but think how nice it would be to have that for adults too. I mean, I don't know, maybe some consultant should come examine the effectiveness of that in pediatrics and try to extrapolate that to other specialties, because I think it could make the hospital experience just a little bit more tolerable and smooth for people. Because that's kind of what your story is about, is that when you feel you don't have control over your situation in the hospital, that can manifest in various different ways, some of which are more productive than others. But I don't know, do you have any thoughts on what might we as a medical profession do to prevent patients from having that feeling of control slipping away? I mean, to a certain extent, it's inevitable.
Yeah, I mean, I have to say, I think we try hard. I don't want to say that people don't do their best, but I do think there are limitations that come up. Time is a huge one, probably the biggest. And so I like to think that every provider I work with, if they had the time, would sit down at the bedside and really explain things to the patient. For a lot of people, I think choice is the biggest thing. And so whenever possible, really emphasizing the fact that the patient does have some amount of control and say in how things go. I think that's really important. Even small choices, like if a patient has a headache and you're about to prescribe them something, there's no harm in asking, do you usually like to take Tylenol or Advil? And that may seem so trivial, but when you've already been told all day long what you have to eat and what medicines you have to take, that could make all the difference.
I like your idea of creating choices even when it seems trivial. And I've noticed that a little bit in my own practice. For example, in the hospital, people are often pretty weak and laying in bed, and I need to listen to their lungs. And the best way to listen to the lungs is to put your stethoscope on their back. And you can't access their back because they're lying in bed. And you say, do you mind sitting up so I can listen to your lungs? And they don't want to because they're tired and they're weak and they just don't want to sit up. And so I changed my approach. And so now I say, I need to listen to your lungs. You can either sit up or roll over to the side and grab the handrail. Which way would you prefer? Mm-hmm. And I find that people are much more willing to reposition their body when you give them the choice like that. This is a really interesting conversation, and as we're talking, it kind of makes me feel like we're reading a book on parenting or a book on how to babysit and how to deal with a child and how to present a child with options and kind of manipulate, for lack of a better term, so that everybody's happy, so that they're happy, they feel like they're in control, but you're also getting the outcome that you want. And I wonder, is there something about being a patient in the hospital that is similar to being a child that is cared for? I will say that one thing I have noticed during my training is that physicians, and I mean, it might be different in pediatrics because they literally are children, but in adult medicine, they're not children. These are adults. And sometimes physicians will speak to the adult as if they're speaking to a child. Mm-hmm. Like the tone, it'll be like, good morning, how are we today? So I think that there is something interesting, a connection between being a patient and being a child and having this instinct to want to treat the patient as a child. And I don't think that's always a good thing.
Yeah. So I think that it is a little different in pediatrics. Part of the reason we have child life is because we need to treat these people like children because they're children, and they're often dealing with very, very serious and adult concepts. And so you reminded me actually of a patient I took care of who was this really sweet 10-year-old who was battling with terminal cancer. And every morning we would come into his room. And let me remind you, this was a 10-year-old who would be reading his paper and having a coffee and a donut. And it was just the epitome of what I would describe usually as somebody, I don't know, who's middle-aged. I don't even read the paper with a coffee and a donut. And he was this really sweet kid who unfortunately was going through truly the opposite of childhood normalcy. And so I completely know what you're talking about. I remember seeing that often in my adult rotations, and with some of our older kids, I would say that we fall into that trap of kind of infantilizing people. But for the most part, I think in peds, we actually try to bring back childhood into the hospital and some of that joy and carefree nature. And so often we will have conversations more with parents than with kids, depending on their age. And in terms of the question of whether or not there's something inherent to the patient status that makes them draw that out of us, I think that at the
at the core of the relationship, you could say that we're caregivers and they're receiving our care. And that is very analogous to a parent and a child, or another relationship where there is someone who's kind of more vulnerable, and it's an easy trap to fall into.
Agreed. Well, I'd like to talk a little bit about opiates.
Yeah.
It's a very hot topic in the news right now. Very difficult topic to discuss even as a provider, because it can be really complex and confusing and emotional, I think, for all of us. I thought maybe you could start by explaining to the audience what makes opiates so dangerous.
So opiates are a class of medications that we use primarily for pain control. They specifically work on the mu receptor, which is in the nervous system. And we actually don't understand pain very well in the medical community. And even though we have lots of different classes of pain medications, we're not by any means where we would like to be in terms of how we manage pain. And opiates are very non-specific in the way they deal with pain. And they're very strong medications and very addicting is truly the crux of the problem. And for a provider, the crux of the problem lies in the fact that you have to treat somebody's pain ethically, and we want to, but you don't want to go so far in treating their pain as to cause more problems for them. And opiates have a whole slew of side effects, from things that are seemingly not that big of a deal, like constipation, which can then bloom into a full bowel obstruction and another hospitalization, to things that are overtly problematic, like addiction.
Or respiratory depression, overdose, death, which we see a lot on the news as well.
Exactly.
And so I think managing pain outside of the hospital and managing pain inside the hospital are a little bit different. But since your story takes place in the hospital, maybe let's fix our conversation in the hospital.
Sure.
How do you think about pain management in the hospital, particularly when you have a patient like the one in your story who may have a little bit of an unhealthy relationship with those medications? How do you navigate that situation? And this is a question that I'm constantly struggling with. So
yeah,
no pressure to have the perfect answer.
So in our hospital, we really borrow from all the different disciplines, Eastern medicine, Western medicine, anything we can really to avoid giving kids medications. Because again, we don't necessarily want to give them something they don't need. And a lot of these kids have never been exposed to certain medications. And so even small doses can really impact their systems. Now, moving on, for kids who need more than that, we usually try to use a multi-tiered system using medicines that we schedule around the clock to help prevent huge spikes in pain. And then we would use secondary medicines on an as-needed basis when they do start feeling that pain increasing. So my favorite analogy that I use in kids all the time, but I also tell my family members and other people, is that to me, pain is like fire, where it's really easy to blow out a birthday candle, but it's really difficult to put out a forest fire. And so when I talk to my patients about pain, it's best to try to intervene as early as possible before it grows into that really big forest fire that takes a lot to put out. So the idea is to keep it as small as possible with some baseline meds, and then prevent needing these big doses of opiates to put out forest fires.
Right.
What's harder is kids who are really used to being in pain. And it can be really hard when we don't have objective findings that point us to a source of pain. We're people in medicine who we like to see and fix problems. It's very difficult when you cannot see a problem and you don't know how to fix it.
And you talk about that in your story as well. With this patient, you felt you weren't even really sure of the source of her pain to begin with, which made the situation extra difficult.
Yeah, when she had first been admitted, we had a clear reason for her pain. She had cellulitis, and that can be a really painful condition. But once that was treated and resolved, you would have expected the pain to also resolve. But I think she had a lot of sources of pain from both a psychological standpoint and an organic standpoint.
And they intermingle so much, the psychological pain and the physical pain. Yes. The boundary between the two can get very blurry at times. And
Absolutely.
That can also make things tough. Well, I'd like to wrap up. I'd like to talk a little bit about this case. You told this story several months ago, and it's definitely stuck with me. Has your thought process around this particular patient or this scenario changed over the last several months since you told the story?
Well, I think that my thoughts about that patient in particular haven't changed too much. I still think about it, and I know my colleagues do as well because we've discussed it. It's really stuck with pretty much anyone who encountered this patient. She was just so memorable, and the experience was one that I think we all will carry through our careers with us. Something that I mentioned in the story is that we're fortunate in pediatrics that we don't have quite as much of a problem of opioids as we do in the adult population. But I do think that the benefit in seeing this kind of case at that stage in my career is that I will carry it forward and, think about the impact of, an order or prescription and how it can really carry out down the line more than I might have otherwise. Even today, I saw a patient in a completely different context who doesn't have a clear cause of pain. And this was an 8-year-old who's never been admitted to the hospital, never had any pain medications. And I specifically said out loud to my attending, I sincerely hope no one prescribes this girl opiates at any point, because I don't think it's what it would treat her. I don't think it would truly treat her pain. And I think it would only lead to these kinds of problems. So it is something I think about on a regular basis.
All right. Well, this has been a really interesting conversation. I hope that we can get more folks from the pediatric world involved, because I just think taking care of kids is a really, it's such an important job, and it takes a really special person to be able to do it and to be able to do it well and to be as thoughtful as you and I'm sure all your colleagues are. So thank you so much for coming and speaking with me and for sharing this story. And let's keep in touch.
Thank you.
All right. That was Dana Gall. What a wonderful conversation. Thanks for listening to The Nocturnist. As usual, we'd love to hear any comments or feedback that you have, so please submit through our website, www.thenocturnistwithans.com. And don't forget to share our show with your friends and colleagues and throw us a rating on iTunes. Also, I wanted to make an announcement. Just a few days ago, we had an amazing event on the theme of love here in San Francisco, and we can't wait to share some of those stories with you in later episodes. And for any listeners in the Bay Area, we have an event coming up on Friday, April 20th on the theme of death and dying. So subscribe on our website to be notified when tickets go on sale. I want to thank executive producer Allie Block, podcast producer Marina Poole, Eliana Monroe, Kirk Klock, Celine Ross, Stephanie Muscat, Joseph Monroe, and Blue Dot Sessions for the music. Farewell.